Perfect.
Okay. It is certainly a pleasure this afternoon to introduce all of you to Dr. Philip Patel.
There he
He's
is.
the medical director
Patel.
of the Eisenhower Medical Center Non-Invasive Cardiovascular Services. And he's also president of the cardiac practice that I am a patient in, the Desert Cardiology at Eisenhower. In doing a bit of research on Dr. Patel, it was interesting for me to find out that he's actually the son of a cardiologist. And in fact, he says that from a very early age, it was more or less preordained that he was going to become a cardiologist. Although he does say that while he was in medical school, he tried to keep an open mind for other fields of medicine, but cardiology was always coming out on top. He did his undergraduate work here in California, UC Berkeley, and then went on to the Boston University School of Medicine for his medical degree. And then this was followed by internship and residency studies at the very esteemed Mayo Clinic in Rochester, Minnesota. I mentioned earlier that I did a little bit of research on Dr. Patel. And in addition to finding out that he is one of the Coachella Valley's most highly trained and credentialed cardiologists, he also gets very high ratings from his patients. I did a deep dive into the dark web and found out that he gets 5 stars out of 5 stars from almost all of his patients. They especially appreciate his ability to listen well. They like his communication style. And of course, most of all, they like the fact that he successfully treats their cardiac issues. So Dr. Patel, it's a pleasure to have you with us this afternoon.
Well, thank you very much. Sorry, I'm broadcasting from my office bedroom. My dog is right there. It's a Saturday, so we're casual today. I need to be able to share my screen. So who can do that? Got to give me access.
If you could just go to the bottom of your the computer, it says share screen.
Okay, there we go. Okay.
We are able to see it. Thank you.
I'll just go to big. There we go. So you're still seeing me? You can still see me, right?
We can, yeah.
Okay, so thank you for that introduction. As Kirk said, I am the medical director of non-invasive cardiology at Eisenhower and also the president of Desert Cardiology Center. My topic is a little different from what you have on your agenda. I really was going to talk about early detection of cardiovascular disease and the state of the art for 2021. I'll be kind of brief and I'll leave room at the end for questions. Dr. Khanna, my partner, already went through a few other things. I watched his presentation as well, so hopefully I won't duplicate a whole lot of things. First and foremost, I have no financial disclosures. When we talk about cardiovascular disease, we're really talking about 3 distinct types. One is what we call atherosclerotic cardiovascular disease. Another is valvular heart disease. And the third major category is arrhythmia. There is a 4th type, which is congenital heart disease, which there's a lot of discussion about that too, but I'm going to focus on adult heart disease here, which is ASCVD, valvular, and arrhythmia. So when we talk about atherosclerotic cardiovascular disease, or ASCVD, what is this? So let's give some brief definitions. ASCVD is accumulation of plaque in the vessel, in the artery. And actually, it's in between the inner layer of the artery and the middle layer. Every artery has 3 layers. You have an outside layer, a middle muscular layer, and then the thin endothelial layer, which is really the business end of the artery itself. And plaque is what gets in between the middle and the inner layer and starts to grow and close off the orifice of the artery. It's a confluent process that really affects all the arteries of the body, start from the top of your head all the way down. And it really begins very early in life. Autopsy studies have shown it begins as early as the age of 2 and continues throughout life. Now, regardless of where that atherosclerosis is located, either in the head or in the heart, it's always the same pathophysiology. When atherosclerosis is localized to the brain or the carotid arteries, we call that cerebrovascular disease, and this can lead to stroke. When it's localized to the heart, we call it coronary artery disease, and that can lead to heart attack or heart failure. And when you have atherosclerosis in the extremities, in the lower extremities, we call that peripheral vascular disease, or PAD. And that can lead to pain when you're walking, what's called claudication, or even loss of the limb if it's not treated properly. Now, according to CDC data, approximately 1 in 13 Americans aged 18 and older have coronary artery disease. And it still is the #1 killer in both men and women, more than cancer, more than HIV, more than motor vehicle accidents, more than COVID-19. Coronary disease is still the #1 killer. Valvular heart disease, or VHD. Valvular heart disease is defined as a structural or a functional defect within the valve or valve supporting structures that creates a disruption in normal valve function. And Dr. Khanna showed you a lot of examples of this with mitral valve and the aortic valve. So in the aortic valve, you can have severe narrowing or stenosis, such as aortic stenosis, and he showed you some good examples of that. Or you can have severe leaking of the valve, such as mitral regurgitation. He also showed you examples of that. Now, the prevalence of valvular heart disease is pretty similar between men and women, and it increases by age. This is data from my old stomping ground, the Mayo Clinic, as Kirk mentioned. This is looking at the prevalence of moderate to severe valve disease. The first row is men, the second row is women. And really, after the age of 65, regardless of whether your mitral is in the yellow and aortic is in the green, regardless of which valve, prevalence increases significantly after the age of 65, and it's pretty much the same for both men and women. Now, what is also interesting is the survival after the detection of moderate or severe valve disease without treatment is also significant. And without valve disease in blue and with valve disease in red, you can start seeing early on, within the first 2 years, you get a significant decrease in survival, starting as early as 2 years after detection. Arrhythmias. Now, arrhythmias are the third type of cardiovascular disease we want to talk about, and it is exceedingly prevalent. 0.5% of the entire world's population has some form of arrhythmia. Think about that. 0.5% of the entire world's population has some form of arrhythmia. Here in the United States, the most common arrhythmia affecting people over the age of 65 is atrial fibrillation. I'm sure many of you are aware of it and have heard of it. It's the most common arrhythmia to be hospitalized for. 2.2 million people per year in this country are diagnosed with atrial fibrillation. In fact, it's so common, over the age of 65, it's often called the arrhythmia of aging. The arrhythmia of aging. Now, because cardiovascular disease is so prevalent, and because it continues to impart such an increased morbidity to the general population, early detection really is paramount to have effective treatment and therapy. Early detection, as we talked about, starts with visiting your cardiologist. Another, from my doing a comprehensive history and physical and routine blood work, I'll also order certain diagnostic tests, which will help to deduce what type of heart disease is present. Early detection, let's focus now on atherosclerotic coronary disease in the heart, or coronary artery disease. Early detection for coronary disease requires some type of stress test. Now, there are many types of stress tests. We have exercise stress tests. We have non-exercise or pharmacologic stress tests. And of the exercise, we have a regular treadmill or a bicycle stress test. And then we also add imaging modalities to the stress test to help improve the sensitivity and specificity of disease detection. And these imaging modalities are echo or nuclear. And if we use echo, then it's called a stress echocardiogram. If we use nuclear imaging, it's called stress nuclear testing or myocardial perfusion testing. And I'll explain that a bit more. This is an example of a stress echocardiogram. Here is, in this situation, we take baseline ultrasound pictures of the heart, and I'll talk about echo in a second. We take baseline pictures of the heart at rest, and then we put the patient on the treadmill, and the patient runs until he can't run anymore, he or she can't run anymore, and then we grab that patient quickly, get them back on the table quickly, and image again quickly, and then we get images at post-stress or peak stress. And then we have to compare the two side by side and see if we're having any changes in the wall motion findings. So, the problem with stress echocardiography is you can get nice pictures at rest, but then by the time you get the patient over to the table, You got to get them on their side, arm up, and they got to hold their breath as we're taking the pictures. And they just finished exercising, so they're short of breath. So it's not the best technique. And by the time you actually get good images, the heart rate has dropped below peak stress. And this is also not quantitated by any type of computer algorithm. It's only by your eyeball reading it and saying, I think that looks a little bad compared to that. So that's why stress echo really is not embraced as much, because it is prone to have some error, operator dependent error. Go to the next slide. So nuclear stress testing is what we utilize in our practice, because we have found that nuclear stress testing or myocardial perfusion scanning is far superior. It has a much higher sensitivity and specificity to detect underlying disease. What we currently use is a digital nuclear imaging for the greater part of, I think since the 1950s, when nuclear technology has been used. They've been using the same analog cameras since the 1950s to get nuclear pictures. Digital imaging is the newest paradigm that we have implemented, and we are the only place in the entire Coachella Valley that is doing this right now. And the image acquisition is absolutely superb to detect coronary disease. This isn't actually, this is one of the cameras that we have, and it's a chair, semi-recumbent chair. Here's a patient, he's getting imaged at rest, and then he'll go off to do exercise, either treadmill exercise or pharmacologic exercise. Then after another period of time of rest, he'll come back and sit on the camera, and we'll take post-stress pictures. And then we'll compare the two side by side. Now, the beauty of this is that you get such beautiful picture rendition. Now, this is an example. This is a 47-year-old male who is heavy, overweight, hypertensive, and had chest pain. The first row on top is images acquired from a traditional analog camera, and the images on the bottom are images acquired from the new digital or D-SPECT camera. When a patient is large, it takes a while for the photons to be emitted off the chest, and you have to take a while to accumulate them in the camera and process it. So his resting images took 11 minutes. His stress images took 19 minutes. So a total of 30 minutes to get this image set for this patient on the traditional analog camera. And look at those pictures. If you're seeing them, they are really lumpy, they're bumpy, they're just not sharp, no sharp borders. It's not a very clear picture. Someone's not muted. And then this is the D-SPECT. If you look here, it took 2 minutes on rest and 4 minutes on stress. So we were able to image this guy in only 6 minutes. And look at the quality of the pictures. Look how sharp they are. Sharp, clean, really clear borders, very clear definitions. This is a paradigm shift in how we read these nowadays. And it really has helped tremendously in the diagnosis of patients. So this is myocardial perfusion imaging to detect coronary disease. Now, for valvular heart disease, our workhorse is echocardiography. Almost always, the detection of heart disease will require some type of ultrasound, which is echocardiography. And there's two types. There's transthoracic echocardiography, or surface echo, and there's transesophageal echocardiography, okay? Now, transthoracic is our first imaging tool. It's usually our first tool in our toolbox that we take out for patients almost all the time. It's I'm sure many of you have had an echo. It's a transducer about the size of a small microphone with a little bit of blue jelly. It's applied to the chest. And then sound waves come off this transducer and they hit the heart. And then those sound waves bounce back or echo back to the transducer. And then those sound waves are processed by fancy computer algorithms and translated into a video image for us to have live real-time review, okay? Dr. Khanna showed you some examples of echo. Here's another echo. This is a surface echo of a patient, just so happens to have valvular heart disease with severe aortic stenosis. Let me orient you here. This is the left ventricle. This is the left atrium. This is the mitral valve opening very, very nicely. This is the aortic valve hardly opening, very bright and calcified. And this is the muscle of the left ventricle, which has become very thick because over the years of this stenotic aortic valve, it has to push against a very narrow orifice, so it gets to get thicker and thicker and thicker to push through that valve. The pressure is very high. And this is all derived from a quick 2-second look at this with an echo, and you can say, this is aortic stenosis. So it's a very quick, very early detection of valvular heart disease using echocardiography, surface echo. Now, a transesophageal echo uses the same echo technology, only that the transducer is at the tip of an endoscope that's put down the throat into the esophagus. This, of course, will require sedation. It's done in the hospital setting, but it yields very, very high fidelity images. If you go back one to this, okay, in order to generate this image, I had to put the transducer on the chest. The sound waves had to go through the chest, through the lung, and through the front part of the heart. So in an average sized person, you're imaging over a distance of about this much, okay? And you can get image degradation if the person has COPD or bad lungs. That will interfere with the image acquisition. If the person is very large, that will interfere with the image acquisition. So these are all variables that are eliminated when you put the probe down the throat, because the distance between the heart and the esophagus image is very tiny, only imaging about this much. The esophagus, the heart sits right behind, right in front of the esophagus. Now, here's an example of a patient. This is a transesophageal echocardiogram. And this is a patient who, let me orient you again. This is a magnified view. So you're having the left upper chamber, left atrium. Here's the mitral valve. And this is the left lower chamber, or the left ventricle. And you can see there is a significant amount of leak or regurgitation. So this is severe mitral regurgitation that we're seeing in this patient. Very clear, very sharp. We can really see what's going on. And this is a real patient of mine. And let me show you the next is, and as Dr. Khanna explained, we do the mitral clip procedure. And here's the same patient after we've clipped his valve, and the mitral regurgitation is almost essentially gone. So a very good result for him. But again, all this is visualized so clearly with transesophageal echocardiography. In fact, Dr. Khanna may have mentioned, all of these structural heart interventions that they do require transesophageal echocardiography. So now there are 2 cardiologists in the room all the time doing this. There's the interventional cardiologist on one side of the table, who is what I would call the pilot. And then the echocardiographer, such as myself, I'm on the other side of the patient with the probe in, and we're the navigator. We tell him, go here, go there, go left, go right, go up, go down. And then they're on the other side and they're manipulating the catheter. And together we work as a team to fix these problems. But we couldn't do it without this modality that we have here. There we go. Another nice thing about TEE, or transesophageal echocardiography, is that we can get exceedingly good 3D reconstructions and renditions of the valve. This is a patient who did not get a mitral clip for his severe regurgitation, but got a valve. This is an actual artificial cow valve that has been put into the patient. In this situation, we're looking at what we call the surgeon's view. So if the surgeon were to open your chest and look, this is how the surgeon would see what the valve would look like. So we mimic that view for the surgeon so they get an idea. So we call this the surgeon's view. This is the actual sewing ring that has been sewn. These little lumps are the suture knots. These are the suture knots. These are the leaflets. It's a tri-leaflet valve in the mitral position. This is a cow valve. And you can see it's working very nicely here. However, one of the nice things about TEE is we can also have the ability to put color. Come on. And when we do that, we see the same patient, even though the ring is in nice position, there is a little leak right here. One of the sutures has disrupted, and there's a little jet of blood flow leaking out. This is causing this patient to have what we would call a hemolytic anemia, because it's a high pressure jet and blood is coming out and shearing the blood cells apart. So he's always anemic. So how we fix this, a woman actually, how we fix it is we will put a wire across this hole and get through that and then stick a plug in it. We can do that and fix this problem. That's she's getting scheduled for that. The other beauty of TE is that it also allows us to see very high fidelity structures. Here is in the arrhythmia world, in the EP world, when we put in WATCHMAN devices. A WATCHMAN device, as Dr. Connor may have explained to you, is used for patients who need protection against stroke but can't take a blood thinner. So we put a plug in the left atrial appendage, and here we're able to visualize it very clearly with TE. You got to remember, this is only a 27 millimeter device. So it's about the size of a dime, and we're seeing it so clearly in this with this technology. This is the beauty of TE. It's a very, very sophisticated tool, but really allows us to get great visualization of very small and very delicate heart structures. Okay. Next. So arrhythmia. The third topic is detection of arrhythmia, and this really involves recording the abdomen. We got to catch it. We got to see what it is. Patients come in and say, "I'm having palpitations," or or any of these symptoms, lightheadedness, passing out, syncope. Until you actually see what the arrhythmia is, we don't really know how to treat it. We got to know what we're treating. So that starts with an EKG, but sometimes we need extended monitoring. We use halters, we use an extended halter, and sometimes we can go 30 days on an extended halter. But if we can't catch it in that time, then we go all the way up to an implanted monitor. This is an example of a halter. Nowadays, the old traditional halters used to have many, many wires, 3 wires usually, and they were bulky units. You had to clip on your belt, and really you couldn't wear it for more than a couple of days at most. Nowadays, we have these halters, which are much more cleaner and slick. These are waterproof devices. You can wear them all day, all night. You can take a shower with them. You can swim with them. We have patients wear them for up to 2 weeks, and we can get very good quantification about what's happening when the patients wear these devices. They just have to change the pads every few days, and we give you a whole lot of pads to change. But if, say, we do this and we still can't find out what's happening, and we really suspect there's an arrhythmia, then we go to the next level, which is a loop recorder. This is an implantable monitor that's really about the size of a paperclip. We put it under the skin, in the chest, under the skin, a small little cut incision made with just some local lidocaine, lidocaine, that's all you need. Takes literally not more than 10 minutes. And this monitors the patient all the time. These devices, this little tip at the device is a Bluetooth transmitter. So it transmits 24 hours worth of data to either your cell phone or to another device every 24 hours. And usually we set it up to do it like at 1 in the morning, because that's when most patients are in bed and the box is right next to them or their phone's right next to them. So it transmits automatically that 24 hours worth of data to capture, and then it erases itself. Then that 24 hours worth of data is sent up to the cloud, and it's stored there. Normals are stored in the cloud. If there are abnormals, any abnormals, then they come down to us and we see them the next day. Again, it has a battery life of 3 years, so we usually detect something by that time, okay? So this is a loop recorder. So in the end, successful detection of heart disease really is predicated on early detection. And all forms of heart disease are extremely prevalent in this society, but treatable if we detect it early. So in the end, make sure you see your cardiologist so we can find out what's going on. Well, with that, I'll end, and I'll take any questions. And thank you for inviting me today.
All right, we do have some questions, Bill.
Okay.
And Dr. Patel, thank you. So let me see. First, we'll start with Ed asks, under stress tests, what parameter of the echo are you looking at?
Which stress test are you talking about?
Ed, do you want to clarify?
Yes, I just took me a little bit to unmute myself. This is the stress test where the person exercises and as quickly as you can. After he's exerted, you put him on the table and look at the echo. I asked this question, a little background, because I think of echoes as primarily being able to make visible structural dimensional changes in the heart and valvular changes in the heart, not so much ischemic changes in the heart. So it seems counterintuitive to me. I'm not sure what you're going to look at that's going to be brought out by exercise. I wonder if you can clarify.
So in stress echo, the objective is to determine ischemia by determining regional wall motion abnormality. The first thing that happens in a stress when you're ischemic is the wall stops moving. Okay, that's what happens.
Which wall is that?
It depends. The vessel supplies, certain vessels supply certain walls. The left anterior descending artery supplies the anterior wall. Then the circumflex artery will supply the lateral wall. The right coronary supplies the inferior wall. So depending upon which segment, and when we also segregate the echo segments into, we call it the 16 segment model. We use that for cath, for echo, for nuclear. Everyone's speaking the same language. So if I say the basal inferior segment, that's coming from the right coronary artery. If I say the anterior lateral segment, that could be coming from the circumflex. So we know what segment we're talking about. So when we look at the echo, we look at multiple cuts so that we can visualize all of the segments. And then we can say, is this moving? We can look at it at rest, and it has to have normal contractility. It actually has to contract. That segment has to contract, okay? If that segment's contracting at rest, then after stress, it stops or it widens, okay? It becomes dyskinetic, either becomes akinetic or dyskinetic. That's a sign of ischemia, okay? So that's what we look at, okay? But that requires direct visualization, okay? That's number one. And you got to get a good image to do that, number one. And you also have to get the image acquisition at peak stress before the heart rate falls less than 85% of the maximum predicted value. So when we exercise the patient, we don't exercise them until they say, I'm tired. You want to exercise them, they say they're tired, but you want to exercise them until at least they're 85% of their predicted maximum heart rate and a little bit more. So you take 220 minus your age, that's your maximum heart rate. You multiply that by 0.85, that's 85%. That's the target. So we do that for everybody, and then we calculate that. Then you get them on the treadmill and get them run. Then if they hit that 85% number, get them a little bit more, then stop quickly, grab them, throw them on that table as fast as you can, up on their side with the left arm up, and start taking pictures real quickly, and get all that in between the guy breathing like this. That's why it can be kind of a crappy exam. So that ends up happening a lot. But that's the problem with stress echo. That's why we don't really use stress echo that much. Now, if I want to tell what's your endurance, what's your exercise capacity, then I'll just do a treadmill on you. Okay, that's a different story. Okay, because that will help me tell me what's your exercise capacity, what's your endurance. Then if I need to know what's going on with your valve hemodynamics, sometimes we use a bicycle or supine bicycle echo. It's a kind of a semi-upright bicycle where we're looking at the valve hemodynamics as you're stressing yourself. And that also gives us some important information. Okay.
Thank you very much for that answer.
Sure.
Okay, Paul has two questions. His first is, I'd like to ask the doctor which test renders the ejection factor and the levels.
Okay, so ejection fraction is our measure of heart function. And there are many ways to evaluate ejection fraction. The gold standard has always been cardiac MRI. Okay, that's the gold standard to measure cardiac ejection fraction. Who's the next best? That's up debate. Nuclear imaging will give us an ejection fraction, which is a quantitative image, which is really accurate. Echocardiography can be done as well, but that's also drawing borders around the echo. We can do it. Nowadays, we have also 3D volumetric measurements in echo that can give us a better assessment of the ejection fraction. And cardiac cath can also give us ejection fraction when they do a left ventriculogram, which is kind of the lowest level because that's only in 2 dimensions as opposed to 3 dimensions. So which is the best that we utilize all the time? Well, we utilize echo because echo, like I said, it's our workhorse. It's our #1 tool that we use. I bet you every single one of you have had an echo, correct? I would say. And it's our fundamental tool that we use. We use it all the time to assess if your heart failure, if your heart pumping function is less than 35%, then your heart failure, then you got to get a defibrillator, things like that. So all of the tools will give us an ejection fraction. If we have discordance, like the echo will say one thing and the nuclear will say another thing, then we have other nuclear tools that we use called a MUGA scan to give us a tiebreaker result. We don't yet have cardiac MRI here. We're working towards getting that. That will be the gold standard, though. That is the gold standard. Okay.
His second question is, he'd also like to ask you if you've heard of any advances in bypass surgery using the Da Vinci robot.
So the Da Vinci robot is utilized for minimally invasive surgery, and not just in bypass, but also in valve. And so there's two types of surgery. There's traditional, which is open heart surgery, and then there's minimally invasive. There are many types of minimally invasive where they'll do maybe a mini sternotomy, or they can do an anterior approach this way. They can do submammary. There's different approaches. And then there's robotic surgery using the Da Vinci robot, which they just have like small ports, 1, 2, 3, 4, 5 ports put in, and the surgeon is sitting away from the patient, viewing the screen through a robot and manipulating tools. Here, we do not do robotic cardiac surgery. It's just not done here at Eisenhower. It might be in the future, but right now we don't. We utilize robotic surgery a lot in patients who want to have minimally invasive, who don't want to have a full cut, and it is very effective. And you have to really go to centers of excellence that do that. Okay.
Thank you. 2 more questions, and then we can open it up to anyone who verbally wants to ask. Bob wonders, does the cardiologist have an option on how much sedation is given during the procedure? He's had one or twice, I guess, he's had that uncomfortable feeling during sedation, I think waking up.
You're talking about a TEE procedure?
Is that correct, Bob?
Yes, TEE.
Okay. Well, hopefully it wasn't done by me. I hope not. But you shouldn't wake up. You should be very well sedated.
Thank you.
I appreciate that. And the first one, I was not. The second one, I was completely sedated.
Okay. Well, I hope it wasn't me.
And the last one on chat, Ed asks, what percentage of arrhythmias are unrelated to any other heart condition?
Well, all arrhythmias are related to a heart condition. I mean, they all are coming from the heart. So you can't say it's unrelated. Certain things precipitate arrhythmias. So just say you have simple benign palpitations that's coming from your heart, and that can be triggered by having a lot of caffeine. Or say you have atrial fibrillation. That can be triggered by having extra alcohol. So there are precipitants, but it's all cardiac related, you know, but there are triggers. We know there are triggers of arrhythmias, and atrial fibrillation is the most common arrhythmia that I'm sure all of you are very aware of. Caffeine's a trigger, alcohol's a trigger, any physiologic stress. Sleep apnea is a trigger, because when you're apneic and you're sleeping, your oxygen level goes down, you become hypoxic. That's a physiologic stress, and people wake up with AFib, you know. So that's a common thing.
Are there any, if I may ask for some clarity, are there any arrhythmias that are idiopathic? In other words, of unknown origin or unknown trigger?
There are. There's lots of idiopathic DTs. There are a lot of idiopathic arrhythmias. Idiopathic means we're idiots and we just don't know why it's happening. And we search for potential triggers all the time. We look for electrolyte imbalances. We look for diminishment of blood flow or ischemia as a cause. We look for a scar as a cause. And sometimes you just don't find anything, though, the idiopathic arrhythmias. They do happen. They're rare, but they happen.
Thank you.
Anyone want to unmute themselves and ask a question?
I have a question for Dr. Patel. Actually, one's a statement. You showed that picture of a patient after, I think during a stress test, sitting in that new chair where they're evaluating, what was going on in there, compared to the old table that you laid down and were almost a cripple after the darn procedure. I just had my last one done with that new chair. It is really so much more comfortable to do that. Yeah, really good.
And it was much quicker, wasn't it?
Oh, much quicker. And I remember talking to the techs there, and they say, oh, the clarity of the presentation is better, and you get all kinds of better stuff for you to evaluate. The question, though, is, a question I have, though, is that the hospital is doing quite a bit of modernization in their cath labs and other things going on, a new hybrid center, et cetera. But all along, there's a lot of radiation that was put into patients, to the doctors, to the technicians around. But the new technology, I understand, has considerably reduced that amount of radiation for everybody. Could you comment on that?
Yeah, it was bad. I'll be very honest with you. The radiation levels on the old cath lab, it was hitting. We all wear a badge. They wear these radiation badges every time we go in there, and everyone's badges were hot, and that's a problem. So we had to upgrade this equipment, and now we have much better cath lab equipment. Echo does not give any radiation. Nuclear technology gives radiation. We initially, years ago, used different types of isotopes. We used an isotope called thallium, and then we used an isotope when we were doing these dual isotope studies when I first came with those old cameras, and that gave off a lot of radiation too. So subsequently, we've changed from doing 2-day studies to 1-day studies. We've abandoned thallium altogether. We're using smaller doses of nuclear isotope these days because now we have digital cameras. All of these are meant to reduce the radiation burden to the patient. It doesn't really help for us to try to diagnose your heart disease, but on the other hand, give you cancer. Because this is not inconsequential amount of radiation. Medical radiation that patients get from CAT scans and cardiac studies is significant. We have to be aware of that. So that's why we do everything we can to do to minimally follow what's called the ALARA principle, as low as reasonably allowed. And it's been a tremendous success now to modify and do that in the hospital setting too. The nuclear cameras in the hospital are still old. That's the next thing that has to be addressed, but that's not under cardiology control, that's under radiology control. And hopefully they'll get on the bandwagon.
Thank you. Thank you. Are there any other questions from people that might want to ask Dr. Patel?
Okay.
Well, Doctor, we really thank you very much for spending some time with us. That was a super informative session there. We really appreciate it. We know I know as president of Desert Cardiology, you have a lot on your table and on your plate, and but the expansion that's going on is pretty impressive, to say the least. And anyway, we appreciate your time and thank you so much. You're a very caring doctor and a caring person. We appreciate that.
Thank you.
Thank you, Doctor.
Take care. Bye-bye. Thank you.
Thanks a lot. All right, our next session is with a family with a child born with congenital heart defect. Are Cindy and Gavin and Isabella on here?
We're here. Cindy and Gavin are.
There's Cindy and Gavin. Hi there.
Bella's on her own device. Hi. Oh, she's there.
Oh, there's Bella. Bella, how are you? Gosh, I didn't get to see you before. And nice to see you. Well, nice to see you. I'd like to these are the speakers that I'd like to introduce. I spent about 40 minutes or so a few weeks ago talking to Gavin and Cynthia, mom and dad to Isabella. And we had just a wonderful, frank discussion. And they answered all the questions. And I was so impressed by their whole story. And then they even volunteered to have Isabella on there, who was the heart patient. And my goodness, now you are what, 16 years old? Is that correct? 16 years old. Does that mean your dad's trying to take you around driving yet or anything like that?
Yeah, I have my permit, but I'm still working on getting my license.
Okay, all right. So we don't have to be concerned about you being on the freeway yet. That's good. All right, that's good. So anyway, this is a wonderful couple with an amazing story. They also have another daughter. I believe her name is Sophia. Is that correct, Sophia?
Yes.
Yeah, and she's a couple years younger than you. Is that right? Okay. Well, so I'd like to introduce them now, and their story I know really amazes you. So have at it, please.
Well, thank you very much. I really appreciate it. We haven't prepared anything formal. What we talked about yesterday, the three of us, is we would kind of share our experiences, because I think we all saw it through a different lens based on our perspectives, our concerns, and our experiences.
And roles.
And roles. And so that's how we thought we would work through it. And I've also got a handful of pictures, and I'm actually going to share just one slide at the moment. Just bear with me. I'm just going to show Isabella when she was 4 days old. Yeah, so you guys should be able to see. So this is Isabella in the top left. At this point, she was actually in a NICU in Worcester, Massachusetts. So this was prior to her first open heart surgery. But let me tell you a little bit of the story from my perspective, and then I'll open it up to Cindy. So Isabella is our firstborn, and we were, like most new parents, really excited. We'd done the usual prenatal visits. There was nothing remarkable in any of the visits. And she was born in bright and bushy, eyes wide open, staring at the world, ready to meet. And she was just a joy. And everything, her APGAR scores were great, you know, and then Cindy got to hold her tight, and, you know, it was a real phenomenal moment. And at the hospital we were at, about 2 or 3 hours after Isabella was born, it's normal, they take them away for, you know, additional workup, if you like. And I was allowed to go with Isabella to this other area while Cindy relocated rooms and got cleaned up, and, you know, was just waiting to be reunited with Isabella. And there was me, a nurse, and there was Isabella in this room, and the nurse was, you could tell she was a little concerned, and I wasn't really thinking much about it. And I was, and then she called over another nurse, and I heard her say, well, she looks a little blue. Let's check it. I didn't know what being a little blue meant. And that's something I want to share with you. As we went through this, you know, we were completely oblivious. You know, we had no idea what it meant to have cardiac issues. This was just all foreign to us. And what happened over the next maybe 5 minutes, more and more people came into the room, and I got pushed further and further back from the bedside to a point where I could no longer see Isabella. So I knew something was awry then. I'm going to pass it over to Cindy, because she was, at this point, she was in a different room, wondering what is going on.
Yeah, I was wondering. It seemed to be taking a long time, even though I didn't really know what to expect. So I kind of shuffled down the hallway. No one was really telling me anything. And so I just kind of shuffled down the hallway to look for my newborn baby. And I saw Gavin standing outside of the room, and a lot of doctors and nurses were inside with Isabella. And, you know, at that point we were told, well, it's either there's something wrong. Her blood isn't being oxygenated properly, and it's either her heart or her lungs. And they had to transfer her to another hospital, which was down just a few miles away.
Yeah.
And that hospital had a NICU and other pediatric services. So she was transferred, and when she was about 8 hours old, we learned of her diagnosis, which is tetralogy of Fallot. She had a large ventricular septal defect. She had pretty much a malformed pulmonary artery, no valve.
Yeah.
And I'm sorry, is someone saying something? I heard. Oh. And she had some small ASDs. Is there anything else?
No, the major issue was the pulmonary artery was totally atresia, so there was almost no blood going to the lungs, which of course is a big deal. By this time, it was, it was almost midnight on the 23rd of June, which was Isabella's birthday. And I was called basically to the nurse's station to take a call from a cardiologist who we got to know very well over the next few years, Vicky Tintenko, who was at a unit in Worcester, who talked me through, and she was trying to describe it all over the phone, and I just couldn't get my head around what the architecture looked like. And I'm a scientist by background, so I was trying to visualize what this was. And anyway, the take home was that she was at the NICU in Worcester. They had her on IV prostaglandins to keep the pulmonary duct open for a period, because there was no space at that point at the Boston Children's, which is where they were planning on taking her to do the additional surgery. And so, much to our surprise, in essence, what happened the next morning, Cindy checked out of the hospital that we were in, and we trudged off to the NICU at the other hospital in Worcester.
No, you went ahead of me.
I did.
Yeah, because
right.
I remember I spent that first night at the hospital, and of course I couldn't sleep.
It's okay.
And it was a wonderful nurse there who just sat with me all night. I know her shift ended, but she just sat with me the whole night, and I'll never forget it. And then the next morning, Gavin picked me up, and I just checked out of the hospital, and we went over to be with Isabella. And it did take almost a week, I think, until they finally had a bed for her at Boston Children's. And so, in that week, we were learning a lot. We were told that she might have DeGeorge syndrome, which is also known as, there's some number, I forget.
Yeah,
but,
some genetic defect.
Yeah, so she was tested for that, and she didn't have it. So we felt fortunate about that. And she had her first surgery at Boston when she was 8 days old. It was a very long surgery. And she was home about a week later. She got discharged, which was amazing.
Yeah, I mean, we basically lived at Boston Children's. It's a remarkable place if you've ever spent any time there. Here we are, it's obviously a children's hospital. So around us were other children, going through their own challenges. And there were a number of cardiac patients there. But for me, the one thing I remember is that she was born relatively small. She was almost 6 pounds. But she looked so small in these hospital beds because, even though it's a children's hospital, there aren't that many babies there. There's a lot of, younger
preemies.
Yeah,
preemies.
Yeah, but she just looked totally lost in the bed, and there was all the the various wires, cables, beeps. It was a little overwhelming, but and Cindy had to pump her breast milk, and we had to store that in a freezer. We kind of got used to that rhythm, but it was just so alien to us, and we didn't feel at all grounded. So we were certainly really excited when we were able to go home. And we were just talking about this last night, that going from that situation where there was just constant noise and buzz and hum and nurses and doctors, and then our door closed in our house and it was silent, and we both looked at each other.
When we took her home.
Yeah,
for
when
the
we
first
took her,
time.
we go, oh no, now what do we do?
We couldn't wait to get her home. And then when we did, we were terrified. But while those first 2 weeks, when she was in the hospital, of course we were, Gavin was kind of more doing all the learning about what, what was going on with her and taking that in. And I was too, but also I was very concerned about, what this might do for her development and her attachment and things like that. I mean, there were lots of times we couldn't hold her at all, which was really heart-wrenching. Trying to nurse her, but not being able to pick her up. So having to pump down the hall from where your baby is was just a very, I remember just thinking, this is not how it's supposed to be. And so there were lots of worries about, I think, her development. We were told that she would likely have developmental issues, which she did not. She was walking at 9.5 months, and she was speaking in full sentences before she was 2, and just she's incredibly bright, and just has had, an amazing life. And I remember, we were so worried about that, about, well, what will her life be like? And one of the cardiologists in Boston who actually disclosed to us that she has tetralogy of Fallot. And I just burst into tears when she said that. And she thought, oh, I shouldn't have said that. I'm sorry, I don't usually disclose it. And I said, no, these are happy tears. Like, she gave us such a gift telling us that, because here was this example of, a 30-something-year-old woman, healthy, successful. And it was so wonderful when she told us that. It was really helpful. And I know she was not sure if she should have disclosed it, but I'm really glad she did.
Yeah, it made a huge difference because, we were getting ourselves better educated, and there were all these, comorbidities that and co-issues that were talked about, and so we didn't know what to expect. So that was truly wonderful. It really was. Mm-hmm. When they did the heart surgery, I didn't get into some of the technical things, but they in essence fabricated a pulmonary artery for her out of pig tissue, out of porcine tissue. And so she had basically an artificial pulmonary artery and no valve, of course, as you would imagine. And we were told that, these things have a finite life, which didn't really surprise us that much. And, it could be anywhere from a year to 4 years before she'll need some replacement. Well, it transpired we were, very much on the low end of that. It's obviously not native tissue. There's obviously immunorejection that can go on. And so it did start to degrade relatively quickly. And I can't remember how young she was. Was it 10 months?
Her first cath was at 3 months.
First cath, I was thinking of her. Yes, we had to have a cath. I'd forgotten about all the caths.
3 months. So she had her first surgery at 8 days, first cath at 3 months, then a cath at 6 months, then 9 months, then 12 months. And then at 17 months, she had her second heart surgery. The major problem at this point was they had the right pulmonary artery just after the branch point was very constricted, and they couldn't get in a stent, mostly because stents just after the branch point of the right pulmonary artery, she had a collateral artery, and so if they put a stent in, it would have blocked that. And so they really struggled, how to balloon it. So which they did. They ballooned it in that area, but they couldn't put a stent in because they were worried it would occlude, what might be a very important blood supply to the lungs. So that was a constant battle, keeping that RPA open and keeping Isabella, healthy and. Yeah, well, and just thinking about that in terms of a constant battle, she had trouble feeding and gaining weight, and that was probably, outside of being in the hospital waiting for her to have surgery, I would say that was probably the most stressful part for us in terms of our day-to-day lives, trying to feed her, and she really had issues, and then ultimately we had to transition her to hypoallergenic formula because she had a lot of sensitivities, like to dairy, and then we couldn't actually pinpoint it because I kept eliminating things from my diet, first dairy, then soy, then meat, wheat.
Yeah, you lost a lot of weight.
So ultimately and that was a struggle for me because of course I really wanted to breastfeed her, and I felt like that was something that I could do to help promote her health. And that was really hard, not being able to. That
was a real tough
it was the right thing medically for her.
Yeah, it was, but that was really tough for you. Just the simple act of providing sustenance for your daughter. And that was
Well, and I guess we didn't know, I don't remember really understanding that it was directly associated with her heart.
Right.
And now I think there's a lot more information for parents that it's very common for babies with CHD, children with CHD to have feeding issues. We know some families whose children have feeding tubes or have had them. And Isabella never had to have a feeding tube or anything like that.
Right.
So I guess it could have been much worse. But the worry about her growth was very constant. And again, it felt like as a mother, that should be something basic that I should be able to do, is feed my child. And so that was really tough as well, and worrying about her growing. But she is now taller than I am, which isn't saying much because I'm only 5'2", but she still has grown into a lovely, there she is at, what was that age? Like
Four or five.
4 or 5.
Yeah.
There she is with her sister about 2 years ago.
2 years ago. Yeah.
And I don't know, Isabella, we've been doing all the talking. Do you want to chime in?
Yeah, sure. So obviously, you know, everything that they talked about, I was too young to remember. So I'm going to talk about kind of my experience and what I remember. So the earliest surgery I remember was my last open heart surgery. I was 6 years old. Honestly, the main thing I remember is that the hospital had really good lemonade. It did. I wrote an essay about that lemonade.
Okay, good.
Obviously, it's been hard. Physical activity is very difficult for me. I can't play any sports, which I do want to, which has been hard, but it's been a good opportunity for me to find other things that I love to do. Another thing is, yeah, the sports is definitely the big thing, and the physical activity is the main thing that currently affects me. Other than that, I mean, I'm very lucky. My condition currently doesn't affect me as much as it could. So to any parents who have like young kids, I just want you to know that it will be okay. I mean, I'm doing great. I'm doing very well in school. I have a lot of friends. And I've been able to find activities that I love to do. You know, currently I'm preparing to take my AP tests, which I'm very excited about. And
can I brag about you for a second?
If you want.
Okay. She is preparing to apply to college. She's a junior in high school, and
Yeah.
she was finally able to take her ACT, which is, you know, it's kind of like the SAT. It's one of the college entry tests. And she only took it once, and she got almost a perfect score, 35 out of 36, which is, you know, 99 point something percentile. So it's pretty amazing. And we're so proud of her. She just seems like she's unstoppable.
Yeah.
So I see a question in the chat asking where we live. So when I was younger, and a lot of the surgeries they talked about happened in Boston, but currently we live in Southern California, San Diego.
Yeah, we're in San Diego. We moved to San Diego when Isabella was just over 2. But as you heard, she had her third open heart surgery when she was 6. And at that time, we still had significant confidence in Boston Children's. We hadn't developed really good relationships with Rady's Children's here. So we actually flew back to Boston for her surgery. So Cindy and Isabella flew. Sophia was still quite young, and that I flew with her actually on the day of Isabella's surgery out to Boston.
Oh my goodness. And I remember when Gavin and Sophia got to the hospital, Isabella was awake, and her younger sister immediately wanted to rush over to her and give her a big hug. And I tried to stop her. I tried to stop her thinking, oh, that will hurt. And Isabella was just so thrilled to see her little sister and said, it's okay. It doesn't hurt that much. and just really wanted to hug her.
Right.
And that was, I'll never forget that. It's beautiful.
Yeah.
Mhm.
I mean,
And I'm sorry.
no, I was just going to add a little bit of technical. The surgery when she was 6, they were able to put in a pulmonary valve at that point. She'd had some heart enlargement, which is obviously natural with the backflow, but they were able to put a valve in, which was, a big deal. She'd had no valve until then. And in fact, one thing that we have learned throughout this journey, and I remember when we were first talking to one of the cardiologists at Boston Children's, asking about what things what science would be like going forward. And he says, well, it doesn't really matter what I tell you today, the science will really change. And that proved to be true. She had the valve put in through open heart surgery when she was 6, and they had to replace it when she was 10, but they were able to do that by catheterization, which was phenomenal. They hadn't been able to do that previously. And so the advancement of the science, the invasive element of an open heart surgery versus a catheterization, as you all appreciate, is really quite significant. So we were really thankful for the scientific advancements.
Mm-hmm. And we've gotten some questions in the chat about our work with Mended Little Hearts. So, I think my parents were actually involved in like the first Mended Hearts group in Boston when we were out there.
Yeah, well, in 2004, after you were born, we did get involved with the group there. And I think they were just starting, at least there. Yes. And then after we moved out here, I don't think there wasn't one.
Yeah.
And then Julie Marshall was probably here.
Mm-hmm.
She started one in San Diego, and we got involved. And at the point that we got involved, it was really to help, because Isabella was, well, that was maybe 3 or 4 years ago.
Right.
So she was an adolescent and doing well, and we felt like we could offer support and hope for other families. And so I am the Bravery Bag coordinator for San Diego. Sorry? Did you hear something?
No, I heard something. Was there a question there?
No, someone just came unmuted. I muted them again.
Sorry.
Thanks, Mary.
And Gavin is the dad coordinator, although they haven't really been able to have any dad events because
we tried to have. I figured I could get a bunch of dads together to watch some football. And so I chose an event, and I was the only one there. And then COVID kind of hit.
But Isabella, you talk about what you do.
Yeah, so I'm the team coordinator for Mended Little Hearts. So pre-COVID, I hosted get-togethers. We did like picnic potlucks, and we also did educational events. Like we had some doctors from Rady Children's come in and talk about like the process of transitioning from the adult from the pediatric to the adult heart care system. Since COVID, I've been leading weekly team meetings over Zoom where, teens with heart defects can come and connect. And we get people from all over the country and Canada. And it's just been a really good way to connect with people and meet new people. And it's also nice because we talk about things. We can talk about our heart defects, but we can also talk about, who we are as people. We can talk about shows we like, we can talk about our school, we can talk about, just stuff going on in our lives. So it's been a really great way to connect.
Yeah.
And I think someone mentioned that they had a monthly meeting. I would be happy to come in and share my story. I can leave my email in the chat and feel free to reach out to me.
Great. Yeah, so we went from early on in Isabella's life where that's all we could think of was her heart and her nutrition, to a point now where we mostly don't think about it, or rarely think about it. Obviously, when she's going for her cardiac checkup, it's a little bit more on our minds, but really it's a less significant part of our lives in terms of how we think about it. We do know that there's certain things that Isabella can't do, but that's the only way it really manifests. And she's been so involved in many other things. She's a passionate reader, a passionate writer, and a great student. And so, you get it back in many other ways. But,
and she's a great human. She's
yes.
just very kind and incredibly thoughtful, and she's a wonderful big sister to Sophia, a wonderful daughter. We could not be more fortunate. I can't actually see the chat, so I don't know if there are any questions, but we can definitely answer any. I think we have a few more minutes.
I think Isabella's monitoring the chat.
Oh,
yes.
are you? Yeah.
Someone asks, what's my nutrition like now? I have no issues with eating now. All of the, allergies that I might have had as a baby, I've grown out of.
Mm-hmm.
I'm pescatarian by my own personal choice, but other than that, I eat pretty much everything.
And I don't know where she puts it. As you can see, she's quite thin, but she eats a lot.
She does. And she's a very adventurous eater. She was eating raw oysters. I can't remember what age, really very young.
Pretty young.
Pretty young. Now, there is one caveat. She thinks tomato soup is spicy. So anything that's got a remote bit of spice in it.
True. I have no spice tolerance.
But aside from that, she is very adventurous in her eating.
Well, and I will say, I think that the fact that it was difficult for her to gain weight when she was little, it led us to trying lots of different foods, trying to get her to eat lots of different foods. And, I remember when she was 2 or even before 2, before we moved to San Diego, her favorite meal, do you remember this?
I do.
Smoked salmon, pasta, and olives. Like that was her go-to. And we were just always trying to, we could give her put olive oil in things, give her just always trying to try different
additional
foods
calories
for her. And she is a pretty adventurous eater. So I don't know if that's why, but it might be.
Yeah.
So someone asked if I have low energy often. So I would say if I'm not doing much, no, I don't get low energy, but I do get winded from everyday things like going up the stairs, walking for a long time. I definitely get more tired than most people. Mm-hmm. But if I'm not doing, physical activity, no, I don't get tired very often. And thank you so much, Lonnie, for your comments. I'm currently 16.
Yeah, she'll be 17 next month.
Yeah, a month.
There was a question about where Mended Little Hearts, the hospitals that you work with in San Diego. Is it just the one? You're not at Loma Linda, are you?
Well, we're primarily Rady Children's, but I think that we're the only chapter in Southern California. So I have sent by mail bravery bags to people living, closer to the LA area. But primarily we are involved with people who go to Rady's. Yeah.
Isabella, this is Ron. How are you? Thank you so much for your story.
No, of course.
It was so touching. We are beginning to start a youth Mended Little Hearts. We've had several meetings. It's centered out of Portland. And we're looking at how we could start youth groups throughout the country. A little bit broader scope than the Southern California region. I'm here in Bellflower. And I'd love to have you involved with that. They had some success up there in forming a youth Mended Hearts group. It's the group in between, probably your age to the 20s or 30s in between. And we're starting to put that together. So I'll send you some information that we had from the notes that they put together. And then we're going to take a look how we can roll out throughout the country. And it's quite a challenging project because that would mean that we'd have to start youth Mended Hearts at hospitals that haven't had that experience before. But when we have people such as you, Isabella, that would be a great asset to us.
Yeah, of course. My email's in the chat. Feel free to reach out to me. I'm happy to help.
Okay.
Nice.
Great.
I wonder, I would like to make a comment. One of the two things. First of all, Mended Hearts puts out a magazine. You won't be able to see it on my little screen, I don't think. Well, maybe you are. It's called Heartbeat, comes out. And Bella was a featured person in that magazine last issue. And what a nice article about that too. And the same thing talking about Julie Marshall in there as well. But one of the reasons to have this story from the family here and Isabella, it shows great hope and encouragement. Earlier in the morning, we used a slogan that said, turn your scars into stars. And if this doesn't absolutely epitomize that, I'm not sure what would be. So we are so grateful to that. And thirdly, you know, many of us here, or most of us that are probably on this Zoom session are older people, well, and farther down than 17 years old. Anyway, but we're grandparents, we're great grandparents, and maybe we have our own children or grandchildren that have some kind of an issue, not uncommon to what happened to this family. And hopefully that will provide an awareness that you can ask questions. You can search out a Mended Little Hearts area in your area, or even a remote thing. And this proposal that Ron has done with Isabella and Isabella's willingness to participate, that's pretty terrific. I also did want to ask her, on those Zoom sessions you have with all those kids your age and stuff like that, do you also talk about boys?
No, that is not typically a topic that comes up.
Well, I can see why, because at 16 years old, those boys are they're messed up anyway. So,
but thank you, Bill, for giving that idea to her. Appreciate that.
Well, you know, I think, does anybody have a last minute question for the family here, Isabella? Because we want to let them get on with their Saturday too. So anybody have a question? Well, listen, you know, Gavin and Cynthia and Isabella, we thank you so darn much for being on this with us. It's been such a pleasure to get to meet you. I know that you have a home out near where we live, and as well. And at some time, I hope we can get together and just talk a little bit, come to dinner and all that sort of stuff. That would be fun. So anyway, yeah, we're going to wrap this up on your side of the thing. And again, thank you so much for being with us. I want to we're having a wrap up session now, and I wanted to bring back Ron Manriquez and Angela Manriquez. Angela is Ron's wife, obviously, and has been our assistant regional director for several years, and was elected to become the regional director this July, along with Ron being his second term as president. And then also our current regional director, Marlon Taylor, and they're going to have a few words and we'll wrap up the session. I know that I believe we're going to have a critique of this session the whole day, that Mandy will send out are we just doing that, Mandy, on Monday to send out a kind of questionnaire, and anybody that was registered can get online and say, well, here's what we really liked about this thing. Here's where things that weren't so good and we could improve. And what recommendations that you like to see in the future for either one of these kind of Zoom things, or perhaps when we can get together in person again. So we're so delighted that you're all here, and I'll turn it over to Ron. Unmute, Ron, unmute.
All right, Ron has actually said for me to start, and I promise to take a minute because it's wow, it's just been a great conference, and this is what Mended Hearts is all about. And it's inspiring each other and trying to be the best that we can be as heart patients and caregivers. You know, my name is Angela Manriquez, and I am the assistant regional director, and I have the privilege of having assigned 9 chapters. but I also work with a team of assistant regional directors, and I want to thank them. Beth, Augie, Julie Jasowski, and Linda Hatcher. I see you there. I hope Richard's there somewhere. Please give him a big hug from us. And without them, we couldn't do all the work that we try to accomplish. I'm also, the best part of this job though, is meeting members like you. Some of you I know personally, hopefully in the future, I'll get to know you all on a one-on-one. But I do encourage you to share Mended Hearts and invite your families and friends to be part of our journey to support, educate, and be an advocate for heart patients and families. Bill introduced his daughter. My daughter's already signed off, but she signed up earlier this morning, and I don't know if my brother's still on, but he actually joined to see what we were all about. If you're a guest and you found today's conference beneficial, then I'm going to ask you to log in to Mended Hearts and join in today, because it is free membership and you have the opportunity to have access to excellent heart resources, invitations to educational webinars, and conferences with great speakers. But I do want to give a shout out to all the chapter presidents. And I need to say it really quick: Frank Andrews, Carol Warlier, Marilyn Mitchell, Constance Evans, Fred Sparling, Ed Maroney, and of course, Bill Stark. I want to thank you and your leadership, because it's your hard work and dedication that advances the mission of Mended Hearts. It is great to be alive and help others. It's a motto that I love saying all of the time. And Bill, I wish I could give you the moon. Great job organizing this, hosting. Your wife, Carol, will give you this mug that I have sent to you in the mail.
That's a 70th anniversary cup, special edition. And I hope that came in the mail. Thank you, Bill, so much. You did an excellent job.
Thank you very much.
There it is, good.
I know maybe it's for coffee, but Chablis and Cabernet works well.
It'll fit.
I report to Marlon Taylor. He's our regional director of Western Division. He's got a lot of chapters responsibilities. He doesn't like me to call him boss. I love him. I know many of you do too. Marlon, I'm going to have you speak, ask you to speak. I know you wanted to say a few words.
It was December 2019. COVID was known at that time, but not widely so. Our chapter was having its annual get together for the holidays, and we always had kind of a white elephant type of gift exchange. My wife loves poinsettias, and so do I. So when my turn came up, there was one available, and I chose it. As time went on, and we got into April and May, shutdown came, and we ceased to be able to visit at hospitals in person. The leaves of the poinsettia plant started to drop and fall off of the tree. And it came time that they were all gone. There was nothing left. But I decided, I wonder how long this plant will live if it's given just a little care, a little nurturing, and a little fertilizer. And as it happens, one day this straggly little poinsettia plant started blooming again. And I can go downstairs, and on the fireplace, I can see the blooms of a plant that should not exist at this point. So I look at, you know, Bill's chapter being in a situation where they were about ready to present a conference in person a year ago. And the bloom fell off. There were no flowers. But when the time came, with a little care and a lot of nurturing and a lot of work by Bill and his chapter, the blooms came back. And here we are having a conference. And the same way with Mended Hearts itself. When it first happened, everyone looked at it and the bloom came off. There were no red leaves, there were no red flowers, but with a little care, with a lot of innovation, the fertilizer that inspires people to try to do something else, we moved forward and became better than we ever were. And I believe that as we go forward, we have an opportunity now to be a hybrid organization where we have chapters that may consider not only meeting in person, but broadcasting on a Zoom channel that they have so that they can have a hybrid program going on. So I commend both the national leadership and the local chapter for what they did. And as some of you or all of you or many of you may know, I contracted COVID myself. And during that period of time, Angela bloomed and came forward to keep the communications going with the chapters. Quite frankly, I was pretty out of it. My mind was fuzzy and everything. So Angela, thank you for fulfilling my request to fill in for me and keep things moving forward. With that, I will just thank all of you for what you do for being on this conference and turn it over to Ron Manriquez.
Thank you so much, Arlen. That was great. Really appreciate it. Marlon has been a solid manager and leader in this section for a long time. And he's a humble man, but he's actually have about 40 chapters in the Western region. So he's a quite active gentleman and real knowledgeable. And I really congratulate him for all the work that he's done. Finally, are there any questions for us that we can answer? Any questions at a national level or any questions you may have? I guess everybody is all questioned out. Mandy mentioned earlier about the leadership sections. We're coming up in June. I would encourage all the leaders to get involved in that. It's a great setup and the agenda is there for those that are leaders. Mandy will send that out to you. Just request it from her. The agenda is already set. I had one somewhere, but she'll send that out to you. Well, I turn it back over to you, Bill, and to close it out.
Ron, thank you so much. We appreciate Ron and Marlon's comments, Angela's comments, and yours. You guys' leadership have really done a great job over the past several years here, particularly the last 2 or 3. And you know, we out here in the, as I call the boondocks, we appreciate that. And I appreciate all the encouragement that certainly the 3 of you have given, plus Mandy and Alvos as well. It's been really helpful for all the participants and the speakers. You know, this has been just wonderful. I hope you enjoyed it. I certainly learned a lot, always learn a lot every time we do anything like this. So, and as a final thought, I just, you know, I thought this thing went pretty smooth and I was quite nervous about it for several weeks, as Mandy knows and Angela knows. And but Mandy, I want to again thank you. My goodness sake, you made this thing run so darn smooth today. And you know, this, I think this girl was answering emails like at midnight last night. I'm not sure, but really she is one heck of a person and we're so blessed to have her. So anyway, we're going to sign off. We thank you very much. My final thought process is to everybody is to have a happy, safe, healthy, and vaccinated life, and hope to see you all in the future. Thank you so much.
Thank you, Bill.
Thank you very
Bye-bye.
much.
Take care.
Thank you, Bill. What a pleasure working with you. You're such a professional and a good sense of humor too.
Thank you, Carol. I know you
Thank you.
helped a lot. Thank you, Carol.
Carol.
Hey, Carol.
Thank you, everybody.
For those that are still on, for those of you who are still on here, there is a sign in my office that only a couple know, and it says, "A veteran lives here with his commander-in-chief." So you know where the pecking order is around here.
Bill, it was a great meeting. You did a great job. Great meeting. Did a great job, Bill.
Thank you, everybody. Appreciate it. Thanks so much. So kind, and I appreciate all the help from our chapter people too. They did big time. Thanks a lot.
Bye.
Guys, have a great weekend. I'm going to close the meeting now.
Okay.
Thank you, Mandy.
Thank you.
Bye.
Thanks.